Welcome to Feminism Today, everyone. I'm Sophia Johnson in New York. Over 1,000 cases of monkeypox have been recorded in more than 40 states across the US, though experts believe that is a serious undercount of the real number. The monkeypox virus spreads through close skin-to-skin contact, and its symptoms can include extremely painful lesions that can last for weeks. States are grappling with a rising demand for testing, treatment, and for those vaccines, which have been all short in supply. For more on this, we're joined now by Daniel Griffin, infectious disease physician with also a Ph.D. in molecular medicine. He is a researcher at Columbia University, ProHEALTH, chief of the Division of Infectious Diseases, and president of Parasites Without Borders, and also co-host of the podcast This Week in Virology. Professor Griffin, welcome to Feminism Today.
Oh, thank you, Dr. Johnson. It's a pleasure to be here. I'm excited to talk about this topic, excited to be able to share things with your audience.
Well, thank you. Welcome. Now, monkeypox is very different from COVID-19. It's not fatal, and it generally doesn't lead to hospitalization, is what I'm reading. It's also not spread through the air. People have been getting it from close physical contact, and a monkeypox vaccine was developed long before the current outbreak. Can you explain to our audience what is monkeypox? Did it come from monkeys?
No, this is a great place to start. And the name monkeypox is a historical name, and it actually goes back to the first place that this was recognized, was diagnosed, and it actually was an outbreak of a pox, right? So a blistering vesicular lesion, like chicken pox, in a colony of monkeys in Denmark, in Copenhagen.
Oh, wow.
Now, it was really just incidental. It was noticed then. But then about a dozen years later, they started to realize that, hey, this is something that we're seeing in parts of the world, particularly West Africa, in Ghana, down into the DRC, Nigeria, and a lot of those countries sort of in that bend there of Africa. So monkeys can get it, but it is predominantly not a monkey pox. It's really a rodent pox, but we'll stick with the name for now that people can get.
Okay. Now, current data from the CDC as of July 13th shows that there are well over 1,000 virus cases here in the United States. You've said elsewhere that in the next 2 months, you can expect these numbers to keep climbing because there is an incubation period and testing is going to have to increase. So I guess my question is, why couldn't the public health community nip this in the bud really early, right out of the gate? And, where are we in terms of the trajectory, in terms of managing this disease?
Yeah, I mean, Dr. Johnson, I maybe had a little more optimism going into this, and my optimism is waning. I thought we had learned a lot of lessons from the COVID-19 pandemic, but we seem to be making some of the same mistakes. One of the first things I would say is that you can't make a diagnosis of monkeypox. You can't confirm the diagnosis unless you have access to a test. And we had the same challenges with testing. Just like the early days of COVID, unless you could show that plane ticket that you had just flown in from Wuhan, China, obviously you couldn't have it. So we had those challenges with the initial diagnosis of the Westchester individual. And he was a patient of ours. And then even after we made that diagnosis, we can only test people in Westchester who maybe went to his same synagogue. So we're running into the same issue here. Is the monkeypox testing initially involved auditioning with the DOH, seeing if you were worthy to be tested. We had an individual at Columbia who, initially was denied. And then finally, over a week later, the test was authorized and that gentleman had the monkeypox. And I just had an individual just earlier today. And this was an individual who married 5 children, heterosexual, and he was initially not tested because he did not fall into the right categories. But we're really trying to push this message that, you don't want to have a circular reasoning. If you're only testing a certain population, that's where you'll see all the cases. You've got to test outside that population. We need access to testing. We now have access through 5 commercial labs. We're trying to get in-house testing at other places, but the early weeks, the early months now of this pandemic have been plagued with the same challenges of access to testing as sort of a first barrier.
Mhm. Now, you've said that the US can expect to have 2.5 million vaccine doses by late this year and 7 million by the middle of next year. If the goal is to contain the outbreak and keep it from becoming endemic in the US, is that fast enough? Is that a fast enough pace for the goal?
You know, it's not. It's not. It could have been if we had gotten those vaccines sooner, if we had jumped in sooner with testing, jumped in sooner, because this is a population, at least we're seeing here in New York, that is very excited to have access to the vaccines. This is not something where we have people sort of on the side with the virus, discounting it, minimizing it. Nobody wants to get quote unquote natural immunity from a monkeypox infection. People would much rather get a vaccine in this situation than risk having these painful vesicles break out over their body, on their
Mhm.
face,
Mhm.
in their mouth, in all these other areas. So we have a population that's very excited, receptive, huge demand for the vaccine. And we're struggling. And as this spreads, we have a disease with an incubation of up to 21 days, 3 weeks, so even longer than we saw with COVID. So a lot of people have already been exposed. A lot of people are incubating. Thousands of people are already out there infected. If we had been able to jump in sooner with the vaccines, we really could have done much better.
Mhm. Now, you've mentioned, and we sort of touched on it a little bit a short while ago. So far, the known spread of this outbreak has mostly been has been men who have sex with men. However, there are other conditions under which this virus is infecting people, as you sort of cited the heterosexual male with 5 kids. So, as you've talked about, can we talk a little bit about outreach to just the general public? Really, it feels like it doesn't have to be specific to LGBTQ plus community, but it should just be a general public announcement, or is it not? Or how would you?
Yeah, and that is what I worry about. We are right now, well, up until recently, right? We were only testing men who had sex with men. We were only testing a certain population. We'd sort of fallen into the same trap, almost, I'll say a bit of a racist thing that we fell into early on with the COVID pandemic. Somehow, being of Asian descent or coming from a particular place.
Yeah.
This is a virus. Viruses are, they do not have any particular preference here. The way this virus is spread is direct skin to skin contact in most cases. There can be, respiratory spread. We think of that as less likely, but
Mhm.
the fact that we are seeing it in this particular population, we're only testing that particular population.
Mm.
So we honestly do not know where it is. So we've quickly fallen into the same circular reasoning where we said, oh, it's affecting this population. We've said, oh, let's not stigmatize. Well, forget about stigmatizing. Let's stop only testing that population.
Right.
There are women out there at risk.
Yeah.
There are heterosexual. There are people outside that community. Until we really start testing and finding out who has this virus, we're really letting it get ahead of us, and we're using the same limited testing biases that got us into trouble with COVID-19.
Hmm. Now, given that you've said you expect the numbers to keep climbing for the next couple of months at least, when do you expect the numbers to start going down?
It really has to do with our response.
Hmm.
I really hope that we were going to respond differently. So, number one is testing. And we now have access to those tests through the commercial labs, which I think is so much better than having any sort of gatekeeping. You should not audition if you want to test to see if a patient has something, or you have a patient want to find out if you have something. But then the next is we've got to get rid of that bias. We have to test a lot of people, because if we have this circular bias, even if we have access to the test, we're not going to be testing the number of people that we need to test. So those are the first two that we really need to jump in. But I think we've got months ahead of us, rising numbers, before we really start moving this in the right direction.
Now, we've talked a lot about outreach, just raising awareness and outreach. I wondered if we talk a little bit about what is known about the disease. Why the public health community is really having such a hard time, and even, sort of watching and monitoring the World Health Organization, having such a hard time monitoring it. It's been on the radar for years in parts of Africa. And so I wonder what's really going on here.
Yeah, I do worry about this perception that we have until a disease ends up, in the United States. We don't feel like it's our problem. We feel like we've got enough to worry about. I'm not
Mhm,
sure the mentality there. Um, but even in parts of Africa, there are not great surveillance systems in place. Just a couple months ago, there was a little girl that I was alerted about in Ghana,
mhm,
and she was up near an area where they have a molecular reference lab, and it was a colleague of mine who reached out, and they really suspected monkeypox. I will, give the
mhm.
spoiler right up front. It was finally officially confirmed as monkeypox. There was no access to testing for monkeypox in the entire country of Ghana, a country that
Wow.
has endemic monkeypox. We had to reach out to the US CDC. They had to get involved. Samples needed to be sent to Kinshasa and the DRC. It finally was confirmed. This, nice end of the story did lead to 5 countries in this region now adding the capacity to do that molecular testing. But if we're not testing, if we don't appreciate that we're part of a global community,
Right.
if we don't recognize a problem in West Africa as a problem that's really a plane flight away,
Mhm.
we're not learning the lessons that we hopefully could have learned from COVID-19.
But I wonder what policy recommendations you would have for, say, the CDC. If you had to have a sit down with Rochelle Walensky, what would you say about sort of how, what are we doing here? Like, you know what I mean? Because I find it highly problematic that it wasn't a problem when there were outbreaks all over the continent of Africa. And then, you know what I mean? It seems so like we've come so far, but not really.
Yeah, I always said early on in the early months of the COVID-19 pandemic that the most selfish thing that we could do here in America was vaccinate the world, and I always had to repeat that because people, I think you misspoke there,
Mhm.
and we really have to realize it's in our best interest to care about health problems throughout the world.
Hmm.
We are part of a global community, so even if it isn't just altruism, and Americans tend to be generous, give a lot to charity and the rest. But this is really realizing you can't just think about America first. You can't think about isolation. We live in an interconnected world. And I think the CDC, to really operate as the disease control organization, they need to work with the WHO. They need to work globally. And I think that's a mind shift that Americans, that people here in the US need to shift over to.
Mhm.
You're not doing yourself a favor by waiting until the cat is out of the box, waiting until there's a huge pandemic, and then trying to step in. An ounce of prevention is worth so much more than trying to jump in after the fact.
Right. So the FDA announced that 800,000 additional vaccine units will be coming from overseas. Are those vaccines effective? And will they get to the people who most need them here in the United States?
Yeah, so that's the challenge. There's two sides to that. One is we do actually have a monkeypox vaccine. I mean, that is huge. This Nordic monkeypox vaccine. It looks like we're going to be able to get millions of doses. They actually, some of the components, I hate to say, involved in producing those doses have supply chain issues.
Mhm,
Millions of doses are just not enough. We're going to need more than that.
mhm,
Um, but it does work. We have data demonstrating it works. People always want to know, oh, but that smallpox vaccine that I got maybe back before smallpox was still a thing, people maybe 70s and earlier, that does not look like that's still working. But we do have a monkeypox vaccine that works. We really don't want to use the smallpox vaccine anymore because the side effects really are significant. The risk of myocarditis is not 1 in a million, but maybe 3 or 4 per thousand. It's actually fairly common. So we want to use the newer monkeypox vaccine. It is effective, but we're going to need many, many more doses unless we are incredibly quick at getting this under control.
Let's talk a little bit about symptoms of monkeypox. What should people look out for in terms of symptoms? Should they be wearing gloves to the grocery stores? How can they, what types of preventative measures can we sort of implement socially? Because I don't hear a lot about that, right? With COVID, we heard wear a mask. I'm not quite sure that I've heard any conversation about what to do in terms of prevention.
Yeah. Okay. So this is great. And, every time I hear a lecture on monkeypox, I feel like they're repeating a lecture from, the 1970s or 1980s. And I always say, like, what do you say we stop talking about how monkeypox is supposed to present and let's talk about how monkeypox is presenting?
Right.
So what we're seeing now, and we have over 1,000 cases recognized, diagnosed here in the U.S., over 10,000. If you start looking at Western Europe and the rest of the world, outside of West Africa, we are seeing something that is really indistinguishable from the other chicken pox, herpes, the other pox presentation. We're often seeing before anyone even feels ill, they start to have some lesions, might be some vesicles. Some of them might already be crusted and scabbing. Some might be just forming. Some might be fluid filled with clear fluid. Some might be pustular. It might be on a hand. It might be on the face. It might be down in the genital region. Then, and this is a change from what we've taught classically, is people, it may be 3 or 4 days later that they start to feel crummy, that they start to have the fever.
Mhm.
So the only way it's getting to be recognized now is you've got to test. You've got to have a high index of suspicion. This is not something that clinically you just see and recognize. So that's one of the first things. The second is transmission, and we need to be really I think, humble about this.
Yeah.
The main way that monkeypox is transmitted is through direct contact, and usually a significant amount of direct contact. So, someone's on a plane, there's 200 other people. It will probably not be transmitted to anyone else on that airplane. And we have experiences to support that. Even in a household, the majority of people living in that intimate exposure in a household will not get the monkeypox. It'll be
Mhm.
the minority. But it does not need to be sexual contact. It can be close physical contact. It could be wrestling. It could be, being close and skin to skin contact. But that's the main thing. Now, there are other types of transmission that occurs, and I don't think we need to think the sky is falling. I'm not sure everyone needs to wear gloves when they go to the supermarket, but it can be transmitted from inanimate objects. We think about if you took a bedding or clothes or a blanket from someone who was infectious and covered your naked body. That's quite a bit different than I think most of what we're doing in the supermarket.
Mhm.
Good hand hygiene after going to the supermarket, good hand hygiene after handling things. I think that's going to keep us safe. But I do think we have to be cautious. There will be certain reports, I am certain, where someone has fulminant, they're in the hospital, they're quite ill, they develop a respiratory manifestation. There will be times where this respiratory transmission, that's going to be incredibly rare. This is quite different than COVID. It is a lot harder to transmit this. But as we're seeing, we're learning a lot every day. So we don't want to be too overconfident in thinking we understand everything about monkeypox.
Now, I mean, what's curious here is you've sort of in just beautifully helped us to better understand what it is and how it's transmitted. Where did this idea, where does this story about STDs, where did that come from then?
Well, I think it had to do with some of the early cases. There were a number of events in Europe where there was particularly men, and there was a lot of skin to skin physical contact that was occurring, and that was involved in the transmission. And so it quickly sort of fell into the same thing I think we fell into early with the HIV,
Yeah.
where it was, oh, it's this population, it's something about that population. But as we know, even with HIV, it's predominantly a heterosexual disease when you look on a large scale. It's just there are certain populations when people see it in that population, they start thinking, is the virus in saliva? Yes. Is it in other fluids? Certainly. But where is there a lot of this? It's those lesions. It's on the skin. So it does not require sexual contact, but boy, during sexual contact, there usually is a lot of skin to skin intimate contact. So I think that's where this sort of was first recognized. But we're going to continue to be in the cycle if we don't step beyond that, if we don't start offering testing to women, to people outside of the LGBTQ population.
On the subject of testing, let's talk a little bit about the capacity for testing around the country. Places like New York City, I read that the capacity of the test was only 10 people a day. I don't know if that's still relevant data today. Is that still the case? Do you know where we are with this?
Yeah, so that we are fortunate to be in a place where our testing capacity has greatly improved. I remember the early days of COVID where the largest health system in the state of New York could do 22 tests per day. So they're like
Mhm.
allocating two per hospital. It was where some of the commercial labs, and this is the great thing about this commercial labs, they were already able to do hundreds, thousands. And that's the thing. That is the big step that we made recently. About a week ago, we moved it to 5 commercial labs, LabCorp, Quest, Mayo, a couple others. And these large commercial labs have the ability to really process a large number of tests. So I think now we have plenty of tests. We just need to be doing those tests. We need that index of suspicion. We need to be moving beyond this sort of stereotype and the circular reasoning. We need to start testing so we really understand the magnitude of this, because every person you test and diagnose is one person who potentially can
Yeah,
stop transmitting to others.
yeah, yeah. Should people seek the vaccine if they think they are in a certain risk group, or should they be distributed universally, like they've tried to do with the COVID vaccine, for example? How do you see this?
Yeah, I mean this is really that challenge, and this is that horrible challenge that people in public health have to make. It's sort of looking not necessarily at the individual in front of you, but the greatest good with these vaccines. So there are people who are very low risk. It probably doesn't make a lot of sense for the first vaccines to go to them. There are people who are higher risk, and by vaccinating them, you're actually going to create a better societal good. So that is the challenge, and I think it does make a lot of sense to be looking at high risk populations. But who are those high risk populations? We're going to know if we do enough testing. Right now, we're in the circular reasoning where we think we know the high risk population.
Mhm.
Maybe we're right, but I don't want to look back on this in a month and realize that we were just not testing a population that really should have been accessing this vaccine as well.
I want to talk a little bit about, I mean, clearly we're in an era where virus is just one plane ride away. What's happening in the lab? How are we, how is research managing this space? You know, what are virologists studying? What's on the horizon? What else should we be aware of? I keep thinking about this movie. It's a Hollywood movie, Contagion,
Yes.
and it plagues it. For lack of a better word, it plagues my mind that there's so much out there that the public is just not aware of. What else is on your radar as a scientist?
No, I think that that's a great movie, and everyone should go watch that. Actually, a friend of ours, Ian Lipkin, was the science advisor, and I
Oh,
still remember
wow.
when Ian Lipkin got. He says, "Well, first I had a virus, and then the second week, then I got the COVID." I'm like, "No, Ian,
Yeah,
you had the
yeah,
second week."
yeah,
Um,
yeah.
but I think this is one of the challenges. Is that movie really lays out, the risk, the security challenges personally and as a nation we have with infectious diseases. And unfortunately, we kind of keep, one thing we worry about it, then we lose interest. And what science really needs to move forward is sustainable funding, sustainable
Mm.
support. And so there are a lot of brilliant scientists out there, but a lot of the way the funding cycle, you sort of rush from one to the other to keep your funding going. And we need really good virologists. We need orthopox virologists. We need
Mm,
corona virologists. We need
mm,
retrovirologists. We need really top notch virologists in all these different areas. We need top notch immunologists to help us as well. We need all these researchers sort of ready to go. We can't think once we have an outbreak that we're going to quickly train someone up to speed if we haven't been giving them the support, if we haven't been creating an atmosphere where young people, young, intelligent, excited people are moving into science and research. This is really important stuff. And I think we've got to appreciate that as a society.
I wonder how much collaboration is going on between agencies, CDCs globally. I know there was a big to do in the press with the Wuhan CDC and the CDC here in the United States. And I just wonder how much collaboration is happening. Are we missing something? What's happening in this space in terms of global collaboration around infectious diseases?
Yeah, I think there's been more challenges lately, actually, and part of it was this. It was reasonable to say, could this have escaped from a lab? But it quickly turned into sort of a slur, and I think that really broke down a lot of communication. I think it's really critical that scientists throughout the world, and I think we have a tradition of this going back decades, can rise above politics and
Mm,
really can have that communication because science is something that's valuable for the entire world. And open lines of communication and collaboration are critical. And I do worry again back to the limited amount of support. A lot of researchers struggling for limited funds and limited support is really not great for fostering that collaboration, which we
mhm.
really desperately need at a global level.
Now, I'm thinking about resources, and I'm also thinking about your podcast. You're the co host of a podcast, This Week in Virology. What is happening this week in virology?
So I think one of the great things is that so many people are now listening to This Week in Virology. People are realizing to be an informed citizen. It
Yeah.
actually, virology is something that people need to know about. COVID is still going strong. We're still seeing over 2,000 deaths a week. We're seeing all kinds of interesting issues with boosters and what's the next vaccine to get and when. And now
Mhm.
we have monkeypox on the rise.
Yeah.
Over 1,000 cases in the US, over 500 of those diagnoses just right here in New York.
Mm,
Hopefully, part of that is because people are realizing, recognizing, doing those tests. There's a lot going on in this week, and in this world in virology,
yeah.
and hopefully we're gonna keep being there, giving out our free education, because I think that's really critical.
What should advocacy and activism look like in the era of global pandemics?
Well, I think that, as we've talked about several times, is no one is safe until everyone is safe. Or, as Paul Farmer suggested, one of the biggest challenges we have is the idea that some human beings are less important than others. And I
Mm,
think we really need to push this agenda that we are a global community. Everyone is of value. There are no political boundaries when it comes to infections. They can cross all these boundaries. We talk about our organization, Parasites Without Borders, and
mhm.
that's really infections do not respect these borders, and we need to stop thinking about borders. We need to stop thinking about race, sexual orientation, religion, these other things. We need to just start looking at human beings and cooperating so that we can make these strides that we really desperately need to.
Dr. Daniel Griffin, infectious disease clinician and researcher at Columbia University, New York, and co host of the podcast This Week in Virology. Thank you so much for joining us this week.
Thank you, and everyone be safe.
And that's it for our program today. Remember, you can follow me and the show on Instagram or Twitter. Thank you so much for watching Feminism Today on Free Speech TV. Join us again next week.